talk is on melanoma protocol with Dr. Rebecca C. Smedley. And I'll just take a quick moment to introduce her. So Dr. Rebecca Smedley graduated from the College of Veterinary Medicine at Michigan University in 2000 and practiced small animal medicine in Western Michigan for 4 years. In 2004, she returned to MSU to complete a residency in anatomic pathology at the Veterinary Diagnostic Laboratory. Upon completion of the residency, she was hired as the academic specialist in anatomic pathology in 2007. Rebecca currently is a senior academic specialist and serves as the biopsy coordinator and associate section chief at the MSU VDL. Rebecca's primary interests are tumor pathology, including canine melanomas and oral tumors, the canine hepatic pathology. She has published several articles in peer-reviewed veterinary journals and given several presentations at regional and national meetings in these fields. Dr. Smedley, thank you, and over to you.
Thank you. Everybody hear me okay?
Yes.
Go ahead and share my screen here. Okay. All right. Does that look okay before I get started?
Yes, perfect.
Okay. All right. Thank you for that introduction. So good afternoon, everybody, and thanks for joining us today. So as I said, we're going to talk about melanocytic tumors for the next hour or so. And so I just want to kind of give you a little history on kind of how these protocols have evolved. These guidelines, as part of the veterinary cancer guidelines and protocols, really developed back in 2010 as part of a veterinary oncology initiative. And then again, kind of an update to that was done by the Oncology Pathology Working Group in 2020. I just want to kind of go over that a little bit first. So back in 2010, there was this initiative by the Veterinary Oncology Committee of the ACVP that emphasized the practice of evidence-based medicine. And a white paper was written at that time entitled Recommended Guidelines for the Conduct and Evaluation of Prognostic Studies in Veterinary Oncology by Dr. Webster et al. And this paper was a consensus paper by several veterinary pathologists as well as oncologists. And it was published in a special oncology issue in the Journal of Vet Path in January 2011. So based on established criteria in this white paper, several other papers were written to evaluate prognostic parameters for various types of tumors, including melanocytic neoplasms. So this was the result then also in that January issue. This is entitled Prognostic Markers for Canine Melanocytic Neoplasms, a comparative review of the literature and goals for future investigation. And so its aim was to provide recommendations for prognostication of canine melanomas at any site, and was based on the results of critical literature review by all of the authors to determine which articles and which prognostic parameters best held up to those very specific guidelines that were published in the Webster white paper. And those included things like adequate case numbers, appropriate selection criteria, confidence in diagnosis, materials and methods, robust statistics, and the quality of the outcome data, et cetera. So then in early 2020, a similar project was done that was kind of an update to that 2011 consensus. And again, this was done through the Oncology Pathology Working Group, which is part of the Veterinary Cancer Society as well as ACVP. And through the melanoma subgroup, we reviewed additional manuscripts that were published from like about 2011 to 2019. And again, we used those same critical criteria described in the Webster white paper to determine which prognostic parameters still show prognostic significance. And then most recently now, Dr. Mutin asked me to create the guidelines and protocols as part of this initiative today. And so this paper was done by a slightly different group of anatomic pathologists and oncologists, but again, we all reviewed the literature critically as well. So all of these initiatives have come about because of the difficulties in predicting prognosis of these neoplasms. Some of the difficulties are due to the fact that there are relatively few true prognostic studies. Almost all of the published studies are retrospective. Few have validated outcome and survival conclusions with postmortem findings. And it's difficult to compare studies due to the different classification systems used, the grouping of tumors, and the methodologies for evaluating parameters such as mitotic index or count, like we just talked about in the last hour, as well as growth fraction. So some studies have included amelanotic melanocytic neoplasms without providing definitive evidence of melanocytic origin. And the accidental inclusion of other types of tumors, such as soft tissue sarcomas in a case series that's supposed to be completely melanocytic tumors, may substantially alter the prognostic significance of the parameter being examined. So again, the aim of all of these initiatives have been to improve diagnosis and prognostication and to increase standardization among pathologists and oncologists for reporting, as well as for study design. So, and I'm happy to report that this does appear to be working. There are several very recent studies that have been aimed to compare the various prognostic parameters using the recommended guidelines that we've previously published, in addition to evaluating potentially new prognostic markers. And this increased standardization has allowed for better comparison between the studies and adds to the confidence of the results of some earlier studies. So again, you can find the current recommendations for melanoma reporting on the CL Davis website that Dr. Dark went over earlier this morning. But so for this talk, though, I want to focus more on understanding some basic terminology and just kind of going through how do you diagnose and prognosticate melanomas so that those guidelines will make a little bit more sense. So to begin, we'll talk about just some basic terminology. So melanocytoma, this should be used to refer to a benign neoplasm of melanocytic origin. Nevus really, it lacks a good definition. It was originally used for human birthmarks, but it's been used for benign melanocytic lesions in humans in vet med. But it's not the best term. So we really prefer melanocytoma. Again, this is typically used for cutaneous lesions, as true benign tumors of the oral cavity are probably unlikely. We'll talk about that in a minute. Right here, actually. So there does appear to be a subset of oral and lip melanocytic tumors that display less aggressive behavior. And these have been termed histologically well-differentiated oral melanocytic neoplasms, or sometimes melanocytic neoplasms of low malignant potential. And this term, the HWDM term, was coined by Dr. Esplin in 2008 when he described a very specific group of oral and lip melanocytic tumors that appear to be less aggressive. Again, I probably wouldn't call them benign. That's why I do kind of like the term low malignant potential, but they do definitely have a different behavior than our malignant melanoma. So this would be used to refer to a malignant tumor of melanocytic origin, either cutaneous or oral. And then the term melanocytic neoplasm should be used if we're unsure if a tumor is benign or malignant, or if you're referring to a group of tumors that includes both benign and malignant melanomas. And then we should avoid the term melanosarcoma. While melanocytes do express intermediate filaments like vimentin, similar to mesenchymal neoplasms, they are actually of neuroectodermal origin. So I just do not like that term. Okay, so we'll start with diagnosis. So the first step in predicting prognosis is obviously to make sure you have an accurate diagnosis. So we look for these features to support a melanocytic origin, such as, of course, melanin pigment. They often have a mixed cell shape. We look for that classic owl eye nucleus, or so you kind of see finely stippled to vesiculate nuclei with a prominent central nucleolus. And then those are common things in both cutaneous and oral forms. The presence of neoplastic cells at the submucosal mucosal junction, junctional activity, intraepithelial nests, Pagetoid spread, and lateral and lentiginous spread are also common features, although they are more common probably in the oral and lip forms than in cutaneous ones. So this image just shows an example of a pretty straightforward cutaneous melanocytoma. It's very well differentiated in terms of high pigmentation. So pretty straightforward diagnosis there. Now this is an image of an oral malignant melanoma that is lacking pigment. And I just wanted to use this image to illustrate the different growth phases. So we've got the vertical growth phase, which refers to the dermal, or in this case, submucosal invasion of the neoplastic cells. And then the radial growth phase refers to intraepidermal or intraepithelial growth, as is shown in this yellow boxed area here. So many oral malignant melanomas show radial growth phase, and I'm going to show you why this is important in a minute. Okay, a few more definitions here for you. So that area in yellow is shown now at a higher magnification. So you can better see the junctional activity of that radial growth, which is defined as the presence of aggregates, nests, or individual neoplastic melanocytes in the basal layer of the epidermis. Intraepithelial component is believed to be the primary site, again, of neoplastic cell proliferation. And then this image also highlights the terms lentiginous or lateral spread, which is the intraepidermal proliferation of migrating neoplastic melanocytes, which preferentially reside among basal keratinocytes. So lentiginous spread is used more as a clinical term in human medicine. So really for histologic purposes, the preferred term would be lateral spread. And then we have Pagetoid spread, which is the upward spreading of melanocytes into the epidermis. So neoplastic melanocytes display pagetoid growth when they invade that upper epidermis from the stratum basale. Okay, so and then these images are just showing the presence of neoplastic melanocytes at the mucosal submucosal junction. So in cases that lack junctional activity or lateral spread, we at least look for the presence of these cells at that junction to help support melanocytic origin. So of course, in the upper image, you've got plenty of pigment. That one's fairly straightforward, but in the bottom image, there's very little pigment there. So we're looking for that to try to support a diagnosis of melanocytic origin. Okay, and the next would be again, these types of tumors often have multiple cell types within them. So you can see polygonal, spindeloid, and mixed cell types, as well as several other cell types that are listed in the online guidelines. And you should, if we're going to go to synaptic reporting and for study design, it is helpful to start recording those cell types that you see. Okay, so one of the biggest challenges that we face as pathologists in terms of melanocytic neoplasms is the diagnosis of those oral spindeloid tumors that have to be differentiated from soft tissue sarcomas like a fibrosarcoma. So this case was a perfect example of that dilemma. In our half section that we had, the tumor was entirely composed of non-pigmented spindeloid cells arranged in bundles with no presence of those cells at the mucosal submucosal junction. So from this section, a soft tissue sarcoma would be a very good and maybe even the main differential because it's not present up there at that junction. But because it is an oral canine tumor, we have to consider that this could be an oral malignant melanoma. So in one of the quarter sections, we were fortunate to have enough lateral tissue that showed a somewhat very subtle junctional activity and lateral spread. So in some cases, it may be difficult to recognize these individual neoplastic melanocytes in the epithelium, especially when they aren't pigmented, and to differentiate them from normal melanocytes. So some of the features we look for include retraction artifacts around the neoplastic cells, and sometimes some cellular atypia like anisokaryosis or altered chromatin patterns, some nuclear pleomorphism. So again, it's a very subtle change along the basement membrane here, where we start to seeing a little bit of that rarefaction. You can see it a little bit better here at high mag, and then again up here, even higher magnification. All of these, again, owl-eyed looking nuclei to our neoplastic melanocytes. So one of the take-home messages here is that we really need to encourage clinicians to submit wide lateral margins on oral neoplasms. One reason for this is that it does dramatically increase the likelihood of an accurate diagnosis if we can find these intraepithelial cells. And another reason is so that we can more accurately evaluate the margins for complete excision. So this is really important for prognosis, but also for therapeutic considerations. For example, the Oncept melanoma vaccine is meant to be used only in dogs with locally controlled disease. So if we miss this area here, that dog may not be a good candidate for the vaccine. Even though, it may appear histologically that the main portion of the mass, that submucosal portion, is completely excised, but if we don't have enough of that lateral tissue to evaluate for that lateral spread, there may be tumor left behind. So another common problem we encounter with oral neoplasms is severe surface ulceration. So again, we've got the same issues as in the last case I showed you. There's no pigment. We can't assess for junctional activity or lateral spread. We're not even sure if the cells are present at the epidermal dermal junction or not because we have no epidermis. So again, we also really have to encourage clinicians that are submitting, especially incisional biopsies, we need to remind them to submit non-ulcerated regions and also non-ulcerated adjacent mucosa as well. So as many of you know, there's nothing worse than that like 6mm punch biopsy you get that's just complete spindle cells and you have no overlying epithelium and no pigment. There's just not much you can do with those at that point. And so in addition to differentiating oral spindle tumors from soft tissue sarcomas, as you know, melanomas are known as the great pretenders, so they can resemble several other cell types, including round cell tumors, carcinomas, osteo and chondrosarcomas as well. So this image shows a diagnostic challenge of an oral malignant melanoma with osteocartilaginous differentiation, again, which is one of the cell types listed in the melanoma protocols. So in many of these cases, chondrosarc or osteosarc are differentials. And again, we just look for those same features that we just talked about, but sometimes we still need to go to immunohistochemical labeling then. So that's what we're going to talk about next and how to further diagnose these difficult cases. So in a previous study, we determined the sensitivity and specificity of 9 antibodies. And we found that melan-A, PNL2, TRP1, and TRP2 had the highest sensitivity along with 100% specificity for detecting melanocytic tumors in our study population. We looked at MITF as well, which had a good sensitivity, but it labeled 7 out of 10 of the soft tissue sarcomas that we used as negative controls in our population, so it had a very low specificity. Similarly, S100 had a low specificity as well. In human melanocytic tumors, HMB45 has been shown to have a high sensitivity, but we had a really low sensitivity in our study population. And then same with tyrosinase and tyrosine hydroxylase, they also had very low sensitivities. So in order to increase our overall sensitivity and maintain our goal here of 100% specificity, we combined the first 4 antibodies into a cocktail, and then we applied that cocktail to each of the tumors. And thereby we were able to achieve an overall sensitivity of 93.9% and maintain that 100% specificity, again, for our study population. So if we look at that, basically what the cocktail does is it helps us kind of increase the percentage of positively labeled cells in each tumor, and it increases the intensity of the labeling. So you can see for each individual marker, there's a difference in intensity and sometimes even the area of neoplastic cells that are labeling. You can see, for example, that like for PNL2, there's a little bit higher intensity here and a higher percentage of cells that are labeling. And then when we apply that cocktail, so all 4 antibodies together into one tumor, we can see that there's an increase in the number of positively labeled cells and greater intensity of the labeling. So basically the cocktail kind of makes it easier for us to read small samples in tumors that only exhibit a small amount of labeling with the individual markers. This is an example of that cocktail. Again, this one would be fairly straightforward to read. So both the dermal and the epidermal intraepithelial neoplastic cells are showing nice positive red cytoplasmic labeling. But in other cases, the most common neoplastic cells to label are going to be the intraepithelial cells because, again, these are the most differentiated. So that's what we're seeing here. So in really poorly differentiated neoplasms, you really may have to hunt for those intraepithelial cells. And again, this is where it is really important to have that lateral flanking epithelium because that's the most likely area that you're going to see this type of labeling. And unfortunately, spindeloid variants of melanomas are the least likely to label with any of those melanocytic markers. So if we only have the submucosal portion of a spindeloid neoplasm with no junctional activity, it's unlikely that we're going to see any labeling. So for those negative cases, we cannot completely rule out the possibility of a melanoma. And another complicating factor in interpreting labeling of melanocytic markers in general is that sometimes the necrotic areas, some areas with marked myxomatous matrix, as well as plasma cells and neutrophils can sometimes aberrantly label. And then occasionally we'll have non-melanocytic tumors, such as some of neural origin that may have scattered individual melanocytes throughout the tumor that may label. And so you just got to keep those things in mind when you're interpreting any of the melanocytic markers, and be careful not to call that tumor positive. For our study purposes, we had defined a cutoff as greater than 10% of the neoplastic cells or clusters of at least 20 neoplastic cells that needed to be positive for us to consider the tumor positive for those markers. So what can we do about those oral spindeloid tumors that do not label for any of the melanocytic specific markers, including our cocktail? If the sample was of poor quality or did not contain surface and flanking epithelium, the best approach might be just to rebiopsy. But we've also started to look at some other IHC markers and some genetic expression patterns. So here I just want to touch on some of the potential future possibilities, as another key initiative of this project was to identify future directions. So I'm going to talk a little bit about SOX10 real quick. So this is a transcription factor that is essential for neural crest and peripheral nerve system development and formation of melanocytes. It has been used as a diagnostic marker for human melanocytic tumors and is highly sensitive for spindeloid and desmoplastic subtypes. So it sounded like a good idea then for our dilemma in dogs. In humans, though, it does also label peripheral nerve sheath tumors, myoepitheliomas, granular cell tumors, some mammary carcinomas, and some other types of tumors. Now in humans, soft tissue sarcomas are much less common than in dogs, and they're usually not a differential. So they don't have the same problem that we do. Despite recent use in veterinary medicine, this antibody has not been validated in dogs as a melanocytic marker. And then we also looked at some gene expression patterns. Tyrosinase is immunogenic and essential for melanogenesis, and expression of mRNA tyrosinase has been detected in 100% of investigated human melanomas in some studies, while others found that high mRNA level of tyrosinase in metastatic human melanomas was predictive of overall improved survival. And again, similar studies had not been done in dogs. So recently, we performed a study that is published in Frontiers now to evaluate SOX10 and some of these gene expression patterns. So we examined 20 oral malignant melanomas, 20 subcutaneous soft tissue sarcomas, and 20 suspected oral malignant melanomas that were spindeloid but lacked junctional activity and pigment. So we did immuno for our cocktail, it's the MDX, as well as SOX10 and laminin, and we ran RT-qPCR for these various genes here. What we found is that tyrosinase, CD34, and CLD were the most discriminatory genes in differentiating between oral melanoma and soft tissue sarcoma, with 100% specificity and 65, 95, and 60% sensitivity, respectively. Now, IHC for SOX10, it labeled all 20 of the oral melanomas, but it also labeled 2 of our soft tissue sarcomas, unfortunately. So while it had 100% sensitivity, it only had 90% specificity. And then our cocktail labeled all of the 20 oral melanomas and none of our soft tissue sarcomas. What was interesting is that in our suspect cases, none of them expressed tyrosinase above our established cutoff level. 14 out of 20 of them expressed CALD or CD34 above the cutoff, which confirms soft tissue sarcoma. And then an additional 4 cases were also suspected to be soft tissue sarcomas. None of those cases was confirmed as an oral melanoma based on IHC or mRNA expression patterns. So the conclusions from that study is that we still found our cocktail to be the gold standard, and that mRNA levels, though, of tyrosinase, CD34, and CALD can be used to evaluate suspected amelanotic oral melanomas that are negative for those specific melanocytic markers, the MDX, to more accurately differentiate between oral melanomas and soft tissue sarcomas. And we hope that this type of genetic analysis will be available soon for routine diagnostics. So a little bit of future planning there for you. Okay, next we're going to head on over to prognosis. So the first step in prognostication, again, is an accurate diagnosis, which we just went over. And then an accurate prognosis is going to be critical for appropriate recommendations for primary or adjunct therapy. So the main potential prognostic parameters that have been evaluated in the veterinary literature are listed here. And we're going to focus on location, histologic features, and molecular tests. But the other parameters should also always be attempted to be included when performing prognostic studies as well. So historically, canine oral melanocytic tumors have been regarded as malignant, and cutaneous melanocytic tumors have been regarded as benign. But recent studies have shown that this is not always the case, and that location alone cannot predict prognosis. So Spangler and Cass showed that 92% oral, 74% feet and lip neoplasms that were originally classified as malignant. Of those, only 59% of the oral and 38% of the feet and lip tumors actually showed malignant behavior. And also a subset of cutaneous melanocytic tumors that showed malignant behavior that would have been predicted to be benign based on location and microscopic criteria for prognostication were also reported in that study. So the challenge really is to distinguish less malignant oral and lip melanocytic tumors and malignant cutaneous ones. And so that's where we're going to rely on our histologic features and molecular markers. So all of these histologic features have been investigated as potential prognostic markers, but only the ones shown in red have been shown to be statistically relevant for cutaneous and oral melanocytic tumors. So ulceration and tumor thickness are only predictive of prognosis for cutaneous tumors. So focusing on oral melanocytic tumors first, these histologic criteria can be used to identify two main subtypes of canine oral lip melanocytic tumors, one being oral malignant melanoma and the other being these histologically well-differentiated oral lip melanocytic neoplasms, again, described by Esplin in 2008. Also, they have been referred to as low malignant potential. So in the Esplin study, his group of tumors, they had a 23.4 month mean survival time, and they histologically resemble blue nevi in humans. Excuse me. So these tumors are very characteristic. They're usually raised, non-ulcerated. They're less than 2 centimeters in diameter. They're heavily pigmented. They lack cellular atypia. They have rare mitoses, and they have abundant collagenous stroma. They also often lack junctional activity and lateral spread, which also helps to improve the chance of complete excision and likely plays a role in the longer survival of these tumors. So Spangler and Cass did a very good job of describing nuclear atypia and what would be considered to be low nuclear atypia and what would be considered to have high nuclear atypia. For this population of oral tumors, the histologically well-differentiated ones, they are described as having low nuclear atypia, so less than 30% atypical nuclei. And those features are usually a single centrally oriented nucleolus. So again, kind of like that owl eye appearance. There may be some minimal clumping of chromatin. You might see a little bit of condensation of chromatin along the inner surface of the membrane, or sometimes a little bit extending from the nucleolus to the nuclear membrane. And then cells that lack a nucleolus have fine and evenly dispersed chromatin at the periphery. So this is just an H&E of a tumor with low nuclear atypia. Again, most of them just have one single prominent central nucleolus there. Okay, so these are features that are in strict contrast to oral malignant melanomas, which again often show junctional activity, lateral spread, poor pigmentation, and they will exhibit marked nuclear atypia, you can see here, and often have several mitoses, so a higher mitotic count. And again, if we look at the very strict Spengler and Cass criteria for nuclear atypia, these nuclei are going to have larger nucleoli of less regular shape. They're often eccentrically located. There's often multiple nucleoli, and you might see some nucleoli haphazardly connecting to the inner surface of the nuclear membrane by thin strands of chromatin. They kind of give appearance of a coarsely vacuolated nucleus. So let's talk a little bit more about nuclear atypia. This parameter is subject to inter-observer variation, and different specificities and sensitivities have been determined in the literature. But with rigorous description and standardization of criteria, we can provide some reproducibility. So again, the Spengler and Cass criteria do work. It is a little bit time consuming sometimes to assess percentage of nuclear atypia though in these cells. And there still is going to be always some inter-observer variation. Also, those authors did not assess nuclear atypia in spindeloid neoplasms, especially particularly the ones where they just didn't have enough nuclear detail. But I think this can be done in spindeloid tumors that have sufficiently observable nuclear detail. But for the Spengler paper, it was primarily assessed in those tumors with more of an epithelioid predominant cell type. Sometimes bleaching is necessary to evaluate nuclear atypia, especially in those heavily pigmented tumors. So to do this, what is recommended is that you count 100 to 200 cells at 400x magnification and estimate the percentage of neoplastic cells with nuclear atypia using a threshold of 30% for cutaneous tumors and 20% for oral and lip tumors. So this is, we have seen a high positive predictive value for prognosis of melanocytic tumors that have sufficiently observable nuclear detail by several studies, some of them older and some of them new, 2019 and a couple 2019 papers that have kind of confirmed these findings by Spengler and Cass or supported their findings. 82.5% of oral and lip melanocytic neoplasms were correctly classified with respect to outcome at 1 year using that threshold of 30% by Bergen et al. And then again, Vargas in 2019 had similar findings. And then in terms of cutaneous tumors, a statistically predictive model using nuclear atypia threshold value of 20% for cutaneous tumors has also been shown to work pretty well. And just to further convince you here, at least for oral tumors, this is a Kaplan-Meier survival graphic showing you the marked difference in survival between the two groups when we use that 30% cutoff for oral and lip neoplasms. And as I mentioned before, in the very recent literature, I have seen more and more recent studies that have adopted those rigorous guidelines by Spengler and Cass for assessing nuclear atypia. Again, they're starting to show similar results. So that's good news. Okay, next we'll talk a little bit about mitotic count, which we talked, Doctors Bertram and Donovan talked a little bit in the last hour. So this is one of the most commonly evaluated factors. It is useful as a prognostic factor for melanocytic tumors at various locations. And again, there's some older references that found prognostic significance, as well as some more recent ones that have been added to the list. So again, a lot of the studies had previously referred to it as mitotic index, but now we will refer to as mitotic count, which is the correct terminology. The problem with mitotic count is that in previous studies, it has been defined in many different ways, and it's been assessed in many different ways. So again, it's been very difficult to compare results of older studies. And I won't go through this too much. Again, just to remind you, we were now striving to report the number of mitoses per field of view area. It's recommended that we assess at this point anyway, to assess the number of mitoses in the highest mitotically active area, regardless of tumor location, by avoiding areas of ulceration, necrosis, and inflammation. And again, bleaching may be needed. It's also recommended that if you are going to bleach for our synoptic reporting methods, we recommend that you report with and without bleaching. So in terms of threshold values, oral and lip melanocytic neoplasms with greater than or equal to 4 mitoses per 10 high power field have been associated with an increased risk of patient death within 1 year of diagnosis. And that threshold had a sensitivity of 90% and a specificity of 84%. And to the best of our knowledge, this report provides the only statistically determined threshold value that has been shown to have prognostic significance. The other studies just empirically determined a threshold value for mitotic count. So this is a Kaplan-Meier graphic. Again, for oral tumors, you can see the marked difference in survival between the two groups using that cutoff of 4. So for the threshold for cutaneous tumors, again, this was not statistically determined. And also the other papers had recommended counting in random fields. We are recommending that you count in the area of highest activity just to ensure that we're not missing a more aggressive tumor. I'd rather err on the side of higher rather than lower, and so that we can do some additional testing if needed. So for cutaneous tumors, a threshold value of 3 has been used in the literature with pretty good statistical support. So tumors with more than 3 per 10 high power fields have been associated with shorter survival time. You can read through some of the results there. Okay, so next is, well, first I just want to comment again though, as we just learned too, mitotic count is definitely still going to be subject to inter-observer variation. So while it is very useful, we still have to remember that there is still going to be some inter-observer variation with mitotic count. So that brings us to pigment. This also is difficult to measure objectively with any kind of validated cutoff. But several studies have found that a high degree of pigmentation has been associated with a favorable clinical outcome for cutaneous and oral tumors. But prognosis could not be predicted for tumors with low or moderate pigmentation. So no conclusions could be made. So we have to remember that. Just the high degree of pigmentation indicates a favorable prognosis. We can't make any conclusions about low or moderate pigmentation. And then greater prognostic significance of this parameter when paired with assessment of nuclear atypia for oral neoplasms has been shown. So in general, studies have reported greater than 50% or less than 50% of cells being pigmented. And it's the greater than 50% that has been associated with a better prognosis. So this is a survival graphic for oral and lip melanocytic tumors. Again, the tumors with high pigmentation, greater than 50% pigment, had much longer survival times than those with moderate or low. But again, we could not make a conclusion from for the low or moderate tumors. Okay, and then very quickly, there's a few other parameters that are useful to varying degrees. There are some conflicting results in the literature, but it has been shown pretty well that oral and cutaneous tumors that have deep infiltration and invasion, they do appear to be associated with shorter survival times in the studies listed. So it is recommended to report the deepest tissue layer present in the sections examined and the deepest layer that is infiltrated by the tumor. Okay, and then we have tumor thickness. So this is the newest, fairly well-proven prognostic factor for canine cutaneous melanocytic tumors. So in order to measure this, you basically can just take a ruler, apply it to the surface of the glass slide perpendicularly to the epidermis and measure the largest thickness of the tumor. And in doing so, a threshold of 0.95 centimeter thickness has been shown to be able to predict favorable and unfavorable tumor-related death clinical outcomes. And those threshold values were statistically determined as well. A threshold of 0.75 centimeters was shown to predict the possibility of recurrence and metastasis. Vascular invasion still remains the gold standard for designating a tumor as malignant. I know we're going to hear more about that in some later sessions. And lymphatic vessel invasion in cutaneous and oral tumors, there has been statistically significant differences in the course of disease by some older studies. Okay, and then we've got ulceration. Again, this is only prognostically significant for cutaneous melanocytic tumors, but Laprie et al. Looked at 68 neoplasms. They're both benign and malignant. They did include some digital neoplasms, and those that were ulcerated had significantly shorter survival times, and it was shown to be an independent prognostic factor in that study. Okay, so now we will move on to molecular parameters. I think we're doing okay on time here. So more than one histologic parameter should be used to classify a melanocytic tumor. And when those histologic features conflict with one another, you should report both the favorable and the poor prognostic factors and discuss them. Now, when I see an oral melanocytic tumor with marked nuclear atypia and a really high mitotic count, some of these cases have well above 30 mitoses and 10 high power fields, I'm done. And I make the diagnosis of an oral malignant melanoma. So for those cases, I don't think you need any additional testing in terms of molecular parameters. But for the less ugly tumors, the next step would be to evaluate the Ki67 index. I also tend to recommend Ki67 labeling for most of the cutaneous tumors, as many of those tumors tend to have a low mitotic count and low nuclear atypia, or are kind of right at that threshold value. So those are kind of like our gray zone cases. And surprisingly for those cases, I do tend to see a higher percentage with a high Ki67 index than I would have expected. But similar to the oral tumors, if I have a really ugly cutaneous melanoma with high mitotic count and really ugly nuclei, I call it a cutaneous malignant melanoma, and I'm done. And again, for those cases, I don't think you need any additional testing. But for those gray zone cases, or again, a lot of the less ugly looking cutaneous tumors, we move on to Ki67. So Ki67 is a nuclear protein that is expressed in all phases of the cell cycle, but not in resting cells. So it correlates with growth fraction, not proliferation index. So this is a growth fraction. So Ki67 is more objective. It's semi-quantitative, and it's less subject to inter-observer variation than histologic atypia and mitotic count. It's, again, especially useful for those gray zone cases. And some neoplasms with histologic criteria of malignancy but low Ki67 index have been shown to have longer survival times than expected by histology. And there's, again, some older studies as well as a couple more, a little bit more recent studies that have had similar results. Ki67 index has been shown to be well correlated with nuclear atypia. So we can see the images here on the left. We have marked nuclear atypia and a very high Ki67 index, all these positive red nuclei here, and then more kind of moderate nuclear atypia, less labeled cells, and then low nuclear atypia and a very low Ki67 index. So this Kaplan-Meier curve is for oral and lip tumors, and it again demonstrates that there has been a significant difference in survival demonstrated by using a statistically determined threshold of 19.5, which I'll discuss in a minute as to what the units are for that threshold. But you can see there's definitely a difference in the two groups for survival. And again, this study used a set of malignant melanomas as well as Esplin's more histologically well-differentiated tumors. So the Ki67 index is determined as the average number of positively labeled neoplastic cell nuclei per area of a 1 centimeter squared optical grid reticle at 400x, where we count 5 grid areas and then average the number. And we do this also in the highest labeling area. Now, this is specific for oral and lip melanocytic tumors. It is determined differently for cutaneous ones. But using this grid reticle, it standardizes the area assessed no matter what scope is used. So everybody is going to be looking at the same area. We don't have the problems that we do with the mitotic count. It's also much easier to identify the areas with the most proliferation by looking for this really bright red nuclear labeling than it is to identify an area of high mitotic activity, which is that red stands out much better than mitotic figures do. Now for cutaneous melanocytic tumors, the Ki67 index is expressed as a percentage of positively labeling cells. So 500 cells are counted at 400x. We also use an eyepiece reticle to do this. It just kind of helps you keep track of what cells you've counted. You just kind of go up and down the rows. And a threshold value of 15% was empirically determined and evaluated in regards to survival with Kaplan-Meier survival curves. And they did see statistically significant differences in terms of survival for dogs using a cutoff of 15%. So the percent correct classification of that Ki67 index was 97%, which was higher than mitotic count and other histologic criteria in the study by Lapre. So what is this grid reticle? It's basically just a little piece of paper that you can put in your eyepiece. You can buy one right here at the website given. I think it was currently listed at about $36 or so. And you just insert it into your eyepiece. So it's a 1 centimeter square ocular reticle. And with 40x magnification then, 1 centimeter divided by 40 is 0.25 millimeters. So if we square that, that's 0.0625. So basically, if you're counting 5 grids, you're evaluating an area of 0.3125 millimeters squared. So for scanned slides, you can simply create your own desired area using these dimensions and still create that grid pattern, which just kind of aids in counting cells. But this gives you a very specific area to evaluate. There are a few recently published studies that have evaluated Ki67, but it's unclear what methods they use. So you have to be really careful when you're reading some of these papers. They've actually cited the Bergen reference for the oral tumors, but then they went and reported the Ki67 index as either a percentage or as the number of positive nuclei in 5 high power fields, which is a totally different area than 5 grid areas. So the methodology, it would be completely different, and it's not possible to compare results with that. So just kind of to summarize, some indicators of unfavorable prognosis for cutaneous and oral lip tumors are listed here. So we've got mitotic count with the various cutoffs, nuclear atypia, pigmentation. Again, I just highlighted this one because a pigmentation of greater than 50% has been associated with a favorable prognosis, but less than that, we can't make a sound conclusion for prognosis there. So I'm only showing you here the unfavorable prognostic parameters in this table. Ulceration is significant for cutaneous tumors. And then also tumor thickness is a more recently used prognostic parameter for cutaneous tumors. Level of infiltration, again, more so for the cutaneous tumors. Lymphatic invasion, of course, for both, and our Ki67 index, and just what those thresholds are and how they're reported. Okay, so then lastly, we have just a couple minutes to finish up. I just want to go over some lymph node evaluation, which is really important. Half of oral melanomas first metastasize to the lymph nodes other than the mandibular lymph nodes. So multiple lymph nodes should be evaluated for nodal metastasis. And this is really important to know before determining treatment strategies. So unfortunately, unless there is overt metastasis, histologic evaluation of these lymph nodes can be really challenging. The first problem, of course, is cost. In veterinary labs, we generally only evaluate 1 to 3 sections of a submitted lymph node as opposed to breadloafing the whole node like they do in human medicine. So it's very easy to just miss a micromet. You can see if you take these slab sections, what you're going to get on those various slides. So it's very easy to miss. The other difficulty is that it's often difficult to differentiate between hemosiderin and melanin in some cases. So in this image, you see this marked dark brown to black pigment at the cortical medullary junction that most likely is melanin, but I do like to stain these with an iron stain sometimes to be sure. So I ran a Prussian blue. You can see there's just a little bit of iron, but most of this pigment is not staining. So then the third difficulty would be determining if these pigmented cells are melanomacrophages, draining melanocytes, or neoplastic melanocytes. So the best option to distinguish between melanocytes and macrophages is to run some immunohistochemistry. I prefer to do PNL2. Unfortunately, plasma cells will generally aberrantly label with those markers, but you can usually tell that they're plasma cells, so you just have to remember to not count those. And in this case, the pigmented cells are not labeling. They're very obvious which ones you're interested in. So granted, the lack of labeling doesn't completely rule out that these are melanocytes, but they are heavily pigmented, which would suggest that they should be well differentiated and most likely would label with PNL2. Also, you have to be careful in dogs with mandibular lymph nodes that have pigmented mouths, because a lot of times you see pigmentary incontinence in those lymph nodes. And then just like with mast cells, we can't always differentiate between neoplastic and non-neoplastic melanocytes, but we're going to look for, again, those obvious features like disruption of the normal node architecture, cellular nucleotypia, and things like that. So conclusions. We have to remember that it is impractical to accurately predict on an individual basis the biological behavior of melanocytic neoplasms. Evaluation of nucleotypia and mitotic index in combination with Ki67 index and clinical features will maximize the percentage of correctly classified tumors. An accurate prognosis is becoming more and more important in veterinary oncology, as various treatment options are now available for specific types of neoplasms, and many more clients are pursuing these options. Treatments are often costly. They may involve radical surgeries or costly radiotherapy, chemotherapy, or immunotherapy, and they may have significant or yet unknown side effects. So it is really important to identify which melanocytic tumors require those additional therapies and which will likely be cured by excision alone. Some future parameters to watch, especially in regards to tumor infiltrating lymphocytes. There's some recent studies out there that are looking at various markers, and several of these parameters here look like they have some promise. All of the authors have said maybe a little too early to tell. They need larger case studies and stuff, but I think some of these may hold some use for us in the future. And so lastly, our goal is always to design more rigorous prospective trials to confirm the validity of described prognostic parameters, and especially to evaluate specific treatment protocols that would allow a more targeted therapy approach. So we must continuously update and review our recommendations, and synoptic reporting and standardization of these methodologies between studies may help to identify new prognostic parameters, further evaluate existing prognostic parameters, and compare those parameters. So these are not, again, these are not new recommendations. Back in 1979, a couple authors stated that well-designed prospective studies with standardized clinical staging, histopathologic diagnoses, genetic features, treatment protocols, follow-up, and statistical evaluation are needed to accurately evaluate various treatment modalities for canine melanocytic neoplasms of various body sites. And with that, I would just like to acknowledge the Davis-Thompson Foundation for hosting and sponsoring the seminar, the American College of Veterinary Pathologists also for co-sponsoring the seminar, and my co-authors from these particular guidelines here. And let's see, we might have time for a couple of questions, I believe. So how are we doing questions? I'm not sure. Let's see.
Are you able to open the Q&A, Rebecca, there?
Yep, I just saw one here. So I've got, do you generally utilize manual assessment or image analysis for Q67? We had some trouble getting our AI assessment training. Yeah, so we do only manual assessment here for Q67. Another question here, in diagnostic pathology in cutaneous tumors, it can be very difficult to distinguish between benign melanocytoma and histologically well-differentiated melanomas. If the tumor isn't perfectly benign appearing, would the recommendation for those to be to call them melanocytic neoplasia and discuss that it is on the more well-differentiated aspect of the spectrum, but slightly more atypical than benign, and recommend. Yes, so that's how I report these out. If I have a, in particular, cutaneous tumor that is kind of right at the threshold for the histologic criteria, I will just report it out as a melanocytic neoplasm. And then I'll say in my comments that, you know, most cutaneous melanocytic tumors do exhibit benign behavior. However, you know, there is a population that can be a little bit more aggressive, and we can look at Ki-67 for some added information if the client would like. So, yep, that's exactly what I do. Okay, the next one says the malignant melanoma could be told as melanoma only, or you have to call it malignant melanoma. It's probably personal preference and some semantics. I know a lot of people just say melanoma. I just say malignant melanoma just so that there's no confusion. In older literature, they seem to have used the term melanoma for both benign and malignant forms in the veterinary literature. So I found it a little bit confusing. So I just do it for added clarification. I think most people, when they hear the term melanoma, they assume malignant, but